Good morning, everyone. The National Center for Medical Education, Development, and Research would like to welcome you to our August 27, 2018 webinar entitled Structural Competencies in Healthcare for Migrant and Seasonal Agricultural Workers. Today, we are excited to have one of our national COP partners join us. This webinar is co-sponsored by the Migrant Clinicians Network and the National Center for Medical Education, Development, and Research. Please remember to mute your microphone when joining the webinar. This webinar is being recorded. We will address questions during the Q&A section. Thank you again for joining the webinar. For those joining by telephone, there will be 4 speakers you will hear this morning. I am Catherine Brown, Director for Communities of Practice at the National Center. I will serve as your moderator. Delania Garcia and Dr. Paul Juarez, who I will introduce shortly, will be our speakers. And we will have a Q&A facilitated by our COP consultant at the center, Dr. Thomas Arcury. The National Center for Medical Education, Development, and Research at Meharry Medical College is a HRSA-funded cooperative agreement, and its goal is to identify evidence-based research for training medical students in the treatment and care of persons experiencing homelessness, persons who identify as LGBTQ, and migrant farm workers. We operate under the leadership of Dr. Patricia Matthews Juarez and Dr. Paul Juarez. The aims of the center are to promote medical education, curriculum, and clinical transformation to better address the needs of LGBTQ, persons experiencing homelessness, and migrant farm workers, and to translate and disseminate research findings to academic, clinical, policy, and lay audiences. Within our center, we have 3 communities of practice. Each one focuses on one of our 3 populations: persons experiencing homelessness, migrant farm workers, and persons who identify as LGBTQ. I have listed our 7 principles of practice which occur simultaneously. At the core of our national center are our researchers. The core of their work is clinical transformation in innovative and sustainable ways. I want to allow as much time as possible within the hour for our presenters. So for more information about the National Center, please visit our website, www.ncmedr.org, where you can see our upcoming events on the virtual Communities of Practice calendar, and you can also follow us on Instagram, Twitter, or Facebook. All of our webinars are recorded and posted on our Communities of Practice YouTube channel, which we refer to as COP TV. We would like to invite you to join us on any of our 3 upcoming September webinars. In closing, as Director of Communities of Practice for the National Center for Medical Education, Development, and Research, please feel free to contact me via email kbrown@mmc.edu. I have also listed my contact information and social media handles for you. Thank you. Today's speakers, our first speaker, Mrs. Garcia, is the Director of International Projects, Research, and Development with the Migrant Clinicians Network. Dr. Juarez serves as Professor and Vice Chair of Research, Director, Division of Primary Care Training Research in the Department of Family and Community Medicine at Meharry Medical College. The learning objectives for today's COP webinar, entitled Structural Competencies in Healthcare for Migrant and Seasonal Agricultural Workers, are for participants to be able to identify at least 3 key structural vulnerabilities confronting migrant and seasonal farm workers, to discuss the impact of structural vulnerabilities on disparities in immunizations, pain management, and opioid misuse, to explore practical solutions to addressing structural vulnerabilities in a clinical setting, and to identify strategies to incorporate knowledge of structural vulnerabilities into medical education. The Migrant Clinician Network is an approved provider of continuing nursing education, CME and CNE. Please make sure that you fill out the evaluation form at the end. For any questions, please contact Jillian Hopewell. Her email address is jhopewell@migrantclinician.org. I am now going to turn the presentation over to Ms. Garcia, our keynote speaker for today.
Thank you so much. And I'm excited to be here. I've not been a party to the work that you all have been about evidently for quite some time now, but the communities of learning are always gratifying to watch because of the work that you engage in. I am going to try and see if I can actually gain control here. It says I'm controlling it. So I have nothing to disclose. I have no interest in pharmaceuticals. I'm not related to anyone on this presentation. I have no stock, unfortunately, in any biomedical devices that are, sort of doing so much these days. So nothing to disclose. Thank you all. What I do want to tell you is that the work that I am going to present to you today, where we're looking at the structures that shape clinical interaction and are part of my sort of learning objectives to this, that we overlay the work there, is in my presentation I want to do a discussion also of the fact that I think we need an external to clinical language structure that helps us really talk about some of the forces that prevail when we're looking at folks that like migrant and seasonal farm workers that are trying to access care, and really look at culture and how we formulate that in structural terms, a discussion of culture, so that we really then can assign it the role that it deserves to have. Because there's been a great deal of conversation around culture, but I think with varying degrees of connectiveness in our definitions, as well as then some complete separation of ideas. I'd like to explain a little bit the process of observing and imagining structural interventions. They're not easy. I don't mean to imply that we're going to be able to just sort of look at one and then employ it, but there's the whole need to look broadly at the array in which we're working, the environment in which we're working, and think about the kinds of interventions that we can develop. Discussing the impact of structural issues on care for vulnerable populations is also important, and particularly in the way that it's been developed in medical education, because we really do then want to look at the integration of structural competency in medical education, where we see some great strides being made, and where there's sort of the disconnect, because there's already, if you look at the life cycle of a clinician, there's already lots of clinicians in practice. They are the site where perhaps medical students come and have an opportunity to view how the delivery of care is being managed in that site. And with it then there's just sort of the conflict between what is perhaps being taught in a medical setting and then what's being experienced in an actual medical setting, where care is being delivered directly. The work that I'm going to be describing today is really been, the biggest part of this work has come to me from Seth Holmes. He's an MD PhD out of the Bay Area in California, as well as Jonathan Metzl. And these are the two gentlemen with whom I've worked and under whom I have tried to study to really have a better understanding of structural competencies and the role that I think it can play in clinical care as well as medical education. And certainly I don't know that all of you are familiar with MCN. We are about 32 years old now, 34 years old now. And our work all began with migrant and seasonal farm workers at its core. We've tried to expand our work so that we're really focusing the impact of migration for any population in any labor industry on health. So the impact of migration on health for us encompasses a number of different groups, but we always keep at our core migrant and seasonal farm workers, because they are the heart of the origins of our work. And what I think it's important for us to keep in mind is that this is really a multidimensional issue that we're trying to confront, because we're talking about the environment in which people are learning, we're talking about the environment in which people are practicing, we're talking about the environment out of which patients are coming to care and then returning for their daily living, and then we're talking about the general environment where there's a discussion about healthcare delivery, health education, and so all of these elements are sort of being juggled simultaneously. And it's difficult to keep all of those things in mind, but I'm hoping that we don't become unidimensional, only focusing on the clinician, only focusing on the patient, only focusing on our single clinical interaction, but that we really try and hold in our minds a more global perspective of what it is that we're confronting. And I think one of the first places that we need to begin is in a discussion of culture. When I say culture, it can be very different from what someone else believes. I can be talking about rituals, and somebody else can say, talking about the Latino culture, and they can be talking about values or customs. And I always use as an example that when you read about the Latino population, very frequently what is written in the scholarship is that Latinos are fatalistic, that it is an element of Hispanic culture. And that what I'd like for us to do is step back and say, for a minute, if you are diagnosed with stage 4 cancer and you live in a very rural community in Mexico where healthcare is not delivered even adequately for basic primary care, then your sense that you are likely to die from this cancer and relatively soon is not so much that you are being fatalistic, but that you are being pragmatic. And I think it's that understanding of how we're defining culture and which element of culture we're actually talking about at any given moment can be very different from what someone else brings to that conversation. And so the multidimensionality of culture, I think, is important. I offer as an example, just one clinical case where you have, for example, a Latina. She's in her 40s. She's about 40 pounds overweight. A clinician seeing her or someone in a medical school setting may be thinking, okay, Latinos predisposed to, metabolic process disorders, that diabetes is really a concern. That's where I need to be focusing. And so it is possible for the person to be consumed in discussing treatment and management of diabetes without having a full conversation of, do you have safe housing? Do you have housing where you can cook? Do you have access to refrigeration? Do you have access to grocery stores? Is it within walking distance? Is it safe to walk in those neighborhoods where you are? And really understanding that if we look at the larger structural issues of, say, for example, where farm worker housing is generally located. It can be distant from services. It can be distant from grocery stores and other elements that would make healthy living easier. There may be no sidewalks, no lighting, and walking and exercising would be difficult. And so rather than just focusing on the fact that we have a Latina who's overweight, and the first thing that comes to mind is diabetes as a concern that needs to be addressed, that we can really look at all of the elements then that would affect our ability to address diabetes and the potential for staving it off or addressing it appropriately. And when we look at cultural competence and the discussion around where we are or sort of in a culture talking of health, of cultural competency, we've seen a lot of changes come forward. And I think we've seen different descriptions of actions or different definitions where what we've been concerned with, we're concerned with, 20 years ago or more, was cultural destructiveness, where we were not taking into account the importance of a particular cultural panel for a patient population. And by not attending to it, we were in many ways undermining it and destroying it. And then looking at the fact that we really were not competent and that we lacked the capacity to have a broader perspective on culture. And then I think what we turned to was a real sense that our goal was blindness, color blindness, cultural blindness, that we just needed to be open and even-handed with everybody, which conceptually is really very interesting. But in that blindness, then we're not taking into account the issue of concern for that person that might make it better able to provide health care. We've talked a lot about individuals training and having a pre-competence, that they are starting to understand that there's elements of competence that they need to view, and what it is in their own presentation and interaction with a patient that needs to be considered and potentially modified. Because for a while, the goal was cultural competence and cultural proficiency. implying that somehow we could have a full understanding of all cultures and be absolutely proficient at competently engaging with anyone because of a complete knowledge. And I think that this was a really well-intentioned effort. We've seen it a great deal. A lot of it has been encompassed in medical education over the last 10 or 15 years in an effort to make that single interaction between the clinician and the patient as effective as possible. But I think what really happens then is that we run the danger of a real cookie cutter approach to what's going on. Like the example of the woman that I spoke of previously, which is that we look at the person in front of us, we presume that this might be the cultural aspect of concern for us, these may be the limitations of this particular person because of what we know of them racially, ethnically, by age, economics, or whatever. What it doesn't allow us to do, though, is think broadly of what the person is experiencing now and what of the systems around them, the healthcare system, the education system, the employment system, just daily living, that is making it then very difficult for them to be as successful in their achieving health, in accessing healthcare, and in being able to control their own health than someone else who is in a very different social setting, economic setting, a different racial group where they're not confronting the same challenges. And so this is then the walk, the sort of ungraceful three-legged race that we find ourselves in. We're trying to attend to a patient in front of us immediately who has a particularly potential problem that we feel like we can manage and assist, but their life, it has them engaged and in some cases controlled or at least limited by structures that they cannot confront. And all of this is going on within a system that also has some structures that, if not really viewed fully, can undermine all of our efforts on behalf of this patient. And I think that Paul Farmer was one of the people who first, for me, presented the notion of structural violence. And what he meant in that is that those structures that I was talking about that are beyond our immediate control and come into play, limiting our ability to move forward, needed to be highlighted. And the example that I offer is when I met Paul, almost, gosh, it had to have been 25 years ago or more. He was battling the WHO, the World Health Organization, about the value of providing treatment to individuals with multi-drug resistant tuberculosis. And the standard position of the WHO at that time was that we were resource limited, and that with those limited resources, we could only treat pan-sensitive TB. And that dollars that were diverted to drug-resistant TB were dollars wasted that needed to go to a population that could be more easily saved. And in that, then, the violence against those individuals presented by that structure was to say some lives were worth, say, sacrifice. And it was his perspective that that is not at all what needs to happen. And what we've seen in intervening 20 years is that now there is a complete understanding of the importance and the possibility of treating multi-drug resistant tuberculosis effectively, and the fact that it is incumbent upon us to find those cases and treat it because they are out there living, propagating drug-resistant tuberculosis, and are as important then for community health as the treatment of pan-sensitive TB. So those structures that create a violence in a person's life, such as the WHO when saying we will not treat this form of illness because it is not deserving, or there is really no merit, or that we're not going to get the biggest bang for our buck, is what we're talking about when we talk about structural violence. And I think you've seen graphs like this before where we're talking about the social determinants of health. And I think that when we do an analysis of structural competency and we're looking at the social determinants, as the foundation, that we really then can expand from there and include the impact of that structural violence, and in then contemplating all of those elements, what the person has in front of them as determinants, what we have in front of us as structural limitations, and where that person may have experienced or continue to experience structural violence, and where it is that we're going to then, in that overlay of multiple forces, be able to provide good care. And I think, you know, Venn diagrams have always been my favorite thing in the world, because I think that it gives us the opportunity to look at the fact that it is not just a single force that we need to contend with, that the patient comes to us with all of the elements that we've described, their own culture, their own experience, their own traumas, their own desires, at the same time that they are then trying to interface with a clinician who has their own education, their own orientation about the best way to provide healthcare, their own sense of what the organization in which they are functioning is going to support that work. And that healthcare environment is driven by higher orders in terms of funding that goes to, say, for example, the health center, and how those dollars can be spent, and everybody's internal understanding of who can be given what level of care and how that's going to be managed. And that environment functions way outside of the interaction of just the patient and the provider. But all of those elements are present during the patient encounter. Now, not all of them can be held in mind at the same time, but I think that it becomes important as we're doing our assessments, as we're making a plan for care, as we're talking about what next steps are going to be with our patient, because they need to be kept in mind so that the question can be, are there elements that assist you in your success? Are there forces that are going to make it difficult for you to succeed? And are there elements in the structure of the environment in which you're receiving your care that are going to make it hard for you to be successful as well? And so what we talk about structural competency is not. It's not to say that services are being developed incorrectly, or, you know, that people's biases somehow make us inadequate to the task, you know, and it's all about correcting our behavior. That's really not where I hope this conversation feels that it's being focused. But rather that what I'm saying is that structural competency in any setting, in a clinical setting and in a learning setting, always are more expansive. That we spend some time looking at the interplay between different factors, so that they can see, you know, we're asking clinicians to see the cultural constraints on both that are confronted by the patient themselves and that they are confronting during that effort to achieve sound healthcare delivery. So expansive thinking is often hard when you're preparing to have 7 minutes with a patient who presents with multiple problems. Early in your career, late in your career, in the life cycle of a clinician, the effort to try and do the best for the person in front of you at the moment that the person is in front of you can make it very difficult to keep in mind that, you know, you're looking at groups. You would like to do an improvement of health for the entire population, but we're looking at limitations to services. We're looking at problems in the environment in which people work, the level of education available to the folks with whom we are trying to provide care, whether or not there's adequate housing, as I said, access to healthy foods, and then always, and particularly we see this with migrant and seasonal farm worker, the labor in which they're engaged really creates a lot of structural violences for the people. It's hard work. It's generally unregulated in many parts of the United States. It comes with it dangerous practices and exposure to dangerous chemicals. And so it is particularly difficult to hold in mind then when we have the patient in front of us. And I think it's also important and incumbent upon us to talk about stigma. And the fact that we self-stigmatize and that we are stigmatized by others, and that our views, however benign, frequently create an atmosphere where individuals are stigmatized. For example, we can be great adherents in a medical setting of the sliding fee scale and feel that our patients should take full advantage of an opportunity to have a portion of their care covered by a sliding fee. But in that moment of saying, do you need this? Then neediness and defining oneself as in need is often very stigmatizing, and how that individual is viewed in the care setting oh, this is a sliding fee scale patient, this is not a full self-paid patient, is very often non-verbally communicated in our settings in the way that the person gets diverted. They have to go over here and speak to the eligibility person, whereas somebody before them didn't have to take that path. And we don't see it as a huge difference, but these are all things that are noticeable in our settings, and they create stigma, and they sort of perpetuate it. So I think when we're talking to our students in medical education, it is to really try and be mindful of our language and our practices, but also the practices that we see going on around them in terms of how individuals are identified as less than, needy, undeserving, less deserving, that those are still unspoken evaluations that frequently get made in many healthcare settings. And that the structures can shape our clinical interactions. I think that, for example, if you don't have a setting with good private spaces for healthcare counseling, and you have a limited number of exam rooms, then very often the exam room cannot be taken up for healthcare counseling because the next patient needs to be brought in. And so then healthcare counseling is done out in a much more open place because structurally the shape of the clinic limits the spaces for these private interactions, and they are held much more in a central location where they are in earshot of almost everybody around. And so they shape the kinds of clinical interactions that we have, and that's something to consider. And so what we think about in a healthcare setting then, and I think is often perhaps not the focus of clinical education, because there's so much about the biomedical that we're really trying to make sure that the students have in place, but that when they go into a practice setting, then there's the physical layout that they need to be concerned with, that there's the time constraint because they've been told they need to see, their panel has to consist of 26, 28 patients in a clinical day. How do you get through that many patients in an 8-hour day? So time constraints about how you can commit the amount of time required for full and thorough understanding. And economics, and we think that very often the economics are not present in the individual clinical interaction, but they really are, because we have clinicians being asked to code accurately for the interaction that they're having with the patient. But they look at this patient and they're fearful that they may not be able to pay at the level that code would provide, so they code lower. And it's deciding then that a good effort being made limits the funds that are available to the healthcare site, which in some ways constrain practices, and it becomes an issue of concern. And then I think that it becomes important to look at the social elements, the social position of the individuals that work at the health center, the social position of the patients themselves as it compares to the clinicians. I think we see very often individuals who've come through medical education with some support for health scholarship, and they then need to work off some of that health medical school debt through working in a setting that has a real need for healthcare services. But the social divide between the patient and the work setting, the healthcare setting, can be significant. And how you manage that is really a concern. And I'm not sure that is a topic that is particularly well dealt with in medical education. And then there's the politics and the floating politics all the time. For example, right now, the current administration is looking at redefining public charge. And will they include the use of health care through something like a federally funded health center as relying on the public good? And then that person needs to declare that as a public charge at the time that they're trying to modify their immigration status. And so the politics of what are swirling around us now affect very deeply how healthcare is provided and how it is used. And so, let me back up here. so I would give as an example, my keyboard doesn't like me, I apologize. We'll say that this is Miss Guerrera, and she's in her mid-60s. And there is a discussion of pain, and what is the source of the pain, and how will that pain be managed. And when we look at somebody who is in this age group, my age cohort, but do we know what kind of work that she's done a big part of her life? Is the low back pain as a result of perhaps years and years of farm labor? And is there something that can be done for her in terms of pain management that will provide the kind of relief that she's seeking? But in addition, if there are domestic violence issues in her home, if there is some physical violence as a part of that, and that is also generating some pain, but it is not a conversation that's being had, what is the pain that you're managing, and what is required for the intervention around that pain? And then there is, sort of the long history of research where, people of color very often are not granted pain management at the level that non-people of color or people who Anglos and people of economic means. So there's multiple elements that come into play here. That we, systems where we're told not to provide pain management of a certain kind because it brings greater scrutiny, because it includes greater cost, because it's cost beyond what the individual can afford, because the pain is of a source that is ill-defined and we cannot deal with appropriately in the short amount of time. And so there's lots of structural competency involved in just the view of a single individual in a particular age group of a particular racial ethnic group who comes forward with something as sort of non-specific very often as pain and pain management. And so it requires lots of thought, and I think it requires a lot of education and conversation. And that's why I talk about an extra clinical language structure, that it's not all just about the biomedical, that a woman of a particular age presents with these symptoms, but that we really also take into account that there's forces that limit decision-making choices and options, and so therefore they affect the health of the person. So that when we talk about then not only do you have a house, the question of homelessness, and the person says, indeed, they have a house. They are not homeless. But what we don't ask then is, do you feel safe in that home? Does that home have electricity and running water? How many people do you share with whom you share that home? Do you feel safe around? Are you related to any of them? And so when we're talking about the environments that our patients are confronting, it can't just be about the, sort of the straight question that gets put forward as a part of our EHR. Do you have a housing or are you homeless? But that we really look at, and outside of that, is this a home in which you feel safe and you can function? And so, there are a lot of social structures that really magnify illness. And they do have biomedical and biological outcomes. And so I'm not trying to discount that is also an important thing to consider. But the overlay of those structures and the biomedical has not really been well researched, at least to my understanding. I know that more is being done around that. And looking at the way that bad infrastructure leads to illness and what is our responsibility to address that. For example, potable water in the United States. I think if you ask people, they will say to you, oh yes, the US, absolutely, potable water, accessible from the spigot anywhere in the country. And in very many cases, that is quite true, but there are still very many places where that is not true. And the absence of access to potable water brings with it lots of problems. And so you can have, urban planning decisions that are being made and housing decisions that are being made. The fact that in South Texas, you can have colonias which are unincorporated communities where they have access to electricity at the pole at the end of the community, and then it's all run by extension cord and wire to the individual houses, where it's still a pump at the end of the community and water is portaged into the homes. But those communities are allowed to exist. It's undecided about who's responsible for them. And extending services, municipal services, is often a huge debate. And with that then comes access to transportation, because if you're unincorporated and not a part of the city, generally the transportation doesn't come out there. Banking services and other businesses are not there. And the absence of all of these structures then exacerbate the problems, the biomedical problems biological problems that may result from something like potable water. If you have children who are exposed and then there's diarrheal disease, how do you get them into care? Who addresses it? What's the transportation? How do you pay for it? And what's the possibility that then it infects others and you have a community-wide problem? And so then I think it becomes important for us to sort of talk about culture a little bit differently and try and formulate it in a different way. So that I'm not trying to replace culture or say that culture doesn't exist or that we shouldn't discuss it or that somehow, it has its existence and our reliance on it is as a negative. Not at all. I only want to say that very frequently our use of culture and terms within cultures have tried to clump people together because we're trying to find some commonalities that we can try and address. And that's not altogether wrong, but I think what we need to do is allow each individual to define their own culture and for them to express to us how they see themselves so that then we can respond in a way that allows them to be successful. So that they get to define their own membership within a group, and that membership within a group is fluid, and folks come and go from identifying within a single group, so that when we talk about, farm workers in general, it's not a monolithic thing. We have farm workers that are engaged in orchard work. We have farm workers that are engaged in field work. The chemical exposures can be really different. The fall exposures can be really different. But the person may see themselves in a really different way. They don't see themselves as a farm worker, for example. They're a truck driver, but they pick apples for 3 months out of the year to bolster their own family economic position. So membership within a group needs to be defined by the person, and our understanding of the variety of groups out there and the reality that those groups may confront should really then direct our questioning. Not direct all of our actions only without validation from the individual with whom we are trying to work. And I see this frequently when we start talking about immunization, that you have farm worker children who are coming with their families, and while vaccination rates in the U.S. are not as strong as they are elsewhere, real efforts have been made, and particularly with a process like Vaccines for Children, then you have children who have been well cared for, but they're traveling with their family who have limited resources, limited capacity to then have their medical records immediately available. Immunizations have been provided in the 1 to 2 years here and in the 2 to 5 years over here, and the confluence of those records has never occurred. Mom has a sketchy recall that has happened, but no proof that that's happened, and so then there's often re-immunizing or no immunizing because they believe that it's already been done, and it just becomes really difficult to provide care well for individuals.
Dale, I'm going to stop you for one quick second. We're starting to get, it's great content and everybody's starting to want to ask questions, and we've got 22 minutes. I just wanted to note you to that, because if I start giving you the questions, it'll knock you off the screen. So I just want to.
Well, so really what the last piece that we really want to talk about was the structural interventions and what those might look like. I had wanted to do a case study on opioid use. We may set that aside for now because the structural response that I offer as an example is the origins of the health center program, which is Jack Geiger, went down to the Mississippi Delta, really understood what he was confronting there was not only the absence of health centers that could provide for people, but an absence of access to healthy foods, an access to good housing, potable water, all of the things that we've been describing. And so at that point then, he was looking at a multi-pronged approach. He believed that health centers needed to be built. They needed to be built under the guidance of individuals from the communities who really understood what was needed. But he also understood that people needed to get, prescriptions for healthy food, because it really needed to be a comprehensive discussion, and the intervention couldn't just be the building of a building. It needed to be the building of the building, an integration of the community, a discussion of the structural barriers that the population was confronting, and an effort to address each one of those. And very often what we see in communities is something as simple as a food pantry. It is an important intervention and a response to some of the structural barriers that people are meeting. If they cannot access healthy food at a grocery store because they live too far away, but they do come for their health center visit, and at that visit can have access to healthy food, and it is made available to them without charge and as an aspect of healthcare provision, then that's really an excellent intervention to consider. The discussion of structural humility is one just to say we don't know it all. And it is mutable, and how the person sees themselves and wishes to be seen and wishes to be addressed and described can change over time. And so the humility on our part as healthcare providers is merely to say the person in front of me is deserving of having an expectation of being treated not the way I want to be treated. It deserves to be treated the way they want to be treated. And I think that that's really the biggest difference there. And so I would just say that we need to look at different tools that are now available, and I'm not sure if these are incorporated in medical education training there at Meharry. I know they have been at other places. Because EHRs have really controlled the kinds of questions that are being asked at history taking, then to probe is really very difficult, because there's a lot of the, focusing on the screen and the ticking off, and then not really looking deeper at, do you have the money to live comfortably is one thing. Now, how do you make that money? And when you run out of money at the end of the month, what do you do? And, because there's a lot of questions about how people are able to survive that really affect their health. So I would just recommend that we look at tools along the way that give us an opportunity to look more deeply at how we communicate with folks. And then I think an integration of that whole discussion of structural vulnerability into medical education, and even into pre-medical education. I mean, I think we see it now in a lot of settings where they're trying to prepare high school age students moving into hopefully the pipeline to go into medical education. And really the discussion being around individuals coming in seeking health, our idea of the systems and our understanding of the systems that are in front of us, and our understanding of those barriers and that create vulnerabilities for our patients, and not wanting to take for granted that it is equivalent across the board that anyone who arrives seeking healthcare by virtue of their race or ethnicity or age or income is going to have the same kind of experience as somebody else. And how we really talk about the structures that are set in place that make it hard for people to care for themselves, really then require us to look at our individual patients and say, what is health for you, and how do I help you achieve that? These are the powers that I can bring to bear. What are the powers that are making it difficult for you to be successful? And where's a place that we can get to in between? I think all the competency-based learning is a great deal of important in looking at systems and looking at practices. I would imagine that if you're engaged in a community of practice, I think you are doing a great bit of this work now in terms of looking at the principles of social behavioral sciences and how it affects your interactions with patients. And looking at, there's a great deal of conversation right now on trauma-informed care, and I think the degree of trauma experienced by migrant and seasonal farm workers is really significant in terms of their desire and push to move away from their communities, their transiting from community to community, how they're received in each new community, the difficulty of the work, the availability of the work, not counting the traumas that they may have experienced in their own lives and in their own families as children, as young adults, and as adults now. So it's looking back at the multiple layers of what that individual may have experienced, and what we're really looking at then is, can we provide medical students and healthcare professionals with the kind of personal and professional development that makes them better able to address patients from the perspective of structural vulnerabilities and responding to them as an ally and allowing them to co-author that answer. So let's go to questions.
So let's do this, Dale, because I want to be a good steward of time, and there's so much amazing information. So if we can have Dr. Juarez give the overview of the National Centers updates, and then Tom, if you can facilitate the Q&A, because we are at 11:45 a.m. Central Standard Time. So I'm going to stop share on my end, release it. And thank you all so much for being on, and Dr. Juarez will take the share.
Okay, thank you, Catherine. Instead of, again, I had a short presentation I wanted to do, but let me just provide, there's two things. I was really excited about this collaboration now with the Migrant Clinicians Network. So it sort of takes me back to my roots. And my roots are both my mother's family and my father's family were migrant farm workers. And they sort of came, again, their route was a little different than I think perhaps what you see now, where you have the East Coast, West Coast, Midwest, sort of up the center of the country. Their route was actually from Texas up through Colorado, and then to Wyoming, and then to the Yakima Valley in Washington State. And so the types of farm work that they did was very different than a lot of what we see in terms of fruits and vegetables and things. Well, they were more in terms of potatoes and sugar beets and wheats and farm equipment that took sort of the big farm equipment sorts of things. So again, and they settled in the Yakima Valley, and in sort of from there really began to settle, particularly after World War II. So the history in terms of farm workers in this country, I think, has changed over time. Through the center, through our national center, again, this is one of the three vulnerable populations that we're focusing on. So again, the opportunity to work with the National Clinicians Network or the Migrant Clinicians Network is really personally important for me, and how we begin to train medical students. And my presentation was really covered a lot of the similar ground as Deliana. So again, I don't need to go over that. I think the one thing that I would add, though, is that I think it's important that a lot of times healthcare providers and students in particular need to understand the difference between culture and the situation or the environment that they find themselves in. And I think a lot of times that gets confused. And I recall several situations where when I was working in the Yakima Valley in the school system, where a teacher came up and she said, well, I want you to talk to this student because they're bilingually handicapped and their family doesn't believe in education. And those were interpretations, I believe, that have nothing to do with culture and everything to do with conditions in which the family found themselves. And I think people make that mistake oftentimes. So here at the National Center, as we move forward, and this is sort of the end of our second year in establishing the community of practice, it's to work with stakeholders, both in the academic and the clinical, and and actually involving people who experience again, the situation of being migrant or working in the fields, to sort of help us understand what healthcare providers need to know. But I think the focus on sort of the structural impediments or barriers that people encounter is really critical. And as we move forward with this, is something that we want to make sure that as we make recommendations, and it's not just for Meharry, we're making recommendations for a curriculum for, in terms of nationwide. So that's what I propose that we bring. And I'd like to sort of turn it back to Catherine and maybe to Dr. Arcuri for facilitating the discussion. So thank you.
Thank you so much. So what we like to do now, and I will email this presentation to everyone. We're going to open up the floor for discussion, for questions and answers. And if Dr. Arcuri could lead us through that. And thank you all again.